Okay.
All right. I guess you all have learned a lot from the hypertension guy. I don't know. It's always difficult to talk about hypertension because I can feel for those people in the committee. It seems when they have a recommendation, it seems so easy, but it's so hard to agree on stuff. I could have asked the guy too because people forget about secondary causes of hypertension in all these recommendations they make, and sometimes when you deal with people who have bad hypertension, that's pretty much what you see, a lot of secondary cause of hypertension. And I'm always wondering, when are they going to say, this is what you do with secondary causes of hypertension, or should we screen for them, or put out statements to encourage that, but that's aside. All right, welcome to kidney disease. Are you all awake? All right, well, let's see what we can do in a short time. So today we're talking about nephrotic syndrome and try to make sense of a big scope of kidney problem. For those of you who follow diseases of the kidney, you find that between hypertension and diabetes as the commonest cause of end-stage disease problem, next on that list, depending on what part of the world you're coming from, is glomerulonephritis. Now, glomerulonephritis, of course, includes all your nephritic and nephrotic syndromes, but that's a big chunk of why people end up on dialysis. And so you know that this disease is very big, and we'll try our best to see what we can do in the short time we have. This is not changing. What happened? Okay. All right.
Okay.
So what do I need to hit now? Just this.
Just arrow.
The arrows. Okay. All right.
Did it change from there though?
Would it change from there?
I don't know if it did or not.
It was not working
So,
before. Okay. That's fine. It's always things that happen. All right. Well, let's talk a little anatomy about kidney disease because sometimes it's easier to understand what you're talking about if you know what the structure is actually doing. Okay. So if you look right over here on your far left there, is what on kidney pathology slides you see is what a normal kidney or normal glomerulus will look like. It's just those of us who deal with it know what normal is. You always have to know normal before you talk about abnormal. So the normal kidney or normal glomeruli will have open capillary loops, and that will be what you see here as your those open holes you see in the glomeruli. And you normally see tubules that are back to back, which this doesn't show a lot, but they're tubules. These are all tubules around the kidney that are back to back. And you don't see much separation because of fibrosis, and that you will see in a kidney that suffered some serious damage. Now, if you look at this cartoon, which I must say some disclaimer, I borrowed a lot of slides, pictures that I thought were good from what I saw from the internet that would explain what I want. So wherever this comes up eventually, I'm acknowledging that I took slides online, okay? I can't cite wherever some of these people, I don't know who they were from, but but they look like they could explain what I want to explain. So on this cartoon slides you have from a normal kidney section, if you will come down to this side, this is primarily a glomerular section that's been cut open, you will appreciate that in a glomerulus, which is the whole component, you have cells that surround a glomerular capillary, and those green cells are called podocyte cells. Sorry, I'll go back. And the gray thing there, of course, you see the glomerular basement membrane. Unfortunately, the pointer is not working the way I want. And you can see the mesangial cells, which are in between the capillary loops and kind of help with the cytostructure of the glomerulus to hold the glomeruli together. And then you see that there's an epithelial cell. Sorry, this is not working well. The epithelial cells are the yellow. And if you look with an EM, you will see that those epithelial cells have some fenestrations. And you all know what the fenestrations are for filtration. Now, when you talk about nephrotic syndrome, something has to go wrong with this structure for something bad like protein to leak out of the kidney. Now, who knows what the normal 24-hour protein levels should be in a normal person? Are you allowed to excrete protein out of your urine? Okay, you're shaking your head. Okay, who knows? All right, It's always good to know what the normal is before you begin to identify the abnormal. What would be an accepted 24-hour urine protein that you lose if you collected somebody 24 hours? What range? Okay. I'm sorry? So you're talking about in your spot. Yeah, I'm talking about 24 hours. It's different than your spot is what you talk about. Okay. Now in a 24-hour collection, less than about 150 milligrams of protein in 24 hours should be what you should see as normal. You know, some people in nephrotic, where kidney doctors kind of extend in pregnancy, it gets almost up to 300. You allow for hyperfiltration in some conditions where people get up to 300, but you shouldn't have more than that. And when you start seeing more than that milligrams, 24-hour collection of urine, you begin to worry that something is spilling more than it should. All right, sorry, I won't spend too much time here. So when we talk about nephrotic syndromes, and I was talking about the pathology, about what happens with the normal glomeruli. This introduction, actually, I want to talk about what you will consider injury to the, and how those injuries manifest clinically. So if you have proteinuria, it's normally due to altered permeability of capillary walls, which you all know from the filtration component of fenestration, GBM, as well as the podocytes. The podocytes have a component where they're all involved in allowing for the filtration component of the glomeruli. And then you have hematuria. Hematuria would happen when you have some rupture of the capillary membrane. So blood is spilling out into the urinary space. So there should be a rupture of the vessel wall. Azotemia is when you don't filter nitrogenous waste well. You all know that. And then oliguria can happen with kidney damage as well as edema. Now, edema is normal because you have retention in salt and water retention. And that normally happens with oliguria. When things are not flowing the way they should flow, the distal tubules feel like we need to hold back more. So you start holding back all the salt. Eventually, it results in hypertension, which is due to fluid retention and disturbed renal BP regulation. Okay? Now, there's always a question among nephrologists, what is nephrotic and what is nephritic? You know, it's an age-long question. And you think it's a sharp line that divides those disease entities, but truth be told, there's a merger and spectrum of disease presentation. So a disease that you typically think is purely nephrotic could present with a nephritic component to it. So that it's easy to understand when you say divide into nephritic and nephrotic because they present or they have classic bullet things that make up the component of that disease. However, in real life, as you can see in this table, almost everything you think has some things purely nephrotic. Minimal change is always nephrotic, so you can say that it's gospel truth about it, you know. But almost everything has some plus signs on both sides. And the lower you go down on this table, you see that the pluses are moving from nephrotic to nephritic. But many diseases would present with both components in real life. And that's why you always have to, you know, depend on the kidney biopsy, you know, as the ultimate mark of deciding what eventually is going on with that kidney. Okay? All right, so let's talk about nephrotic syndrome. So what is a nephrotic syndrome? So it's usually caused by injury to the podocyte and all the GBM. And if you remember the normal pathology, the podocytes wrap around the glomeruli and actually support the GBM. If you had to think on your developmental anatomy, you think of cells. There are epithelial cells that make up the podocytes. And your endothelial cells are your vascular wall. And they secrete in between to form the GBM. Whereas your mesangial component, or mesangium, which is the middle area, is made of your mesangial cells. So those three cell lines are found in the kidney, and they do what they're supposed to do. All right? So you have nephrotic syndrome, 3.5 grams, everybody can speed that out. Oh, more than 3.5 grams is nephrotic. Yep. So part of it, proteinuria, if you have more than 3.5 grams, and in children that amount is listed there. They usually have hypoalbuminemia because you're losing a lot of protein from the urine. There's hyperlipidemia, and there's edema, as well as hypercoagulability. That's the one people forget easily. But most people with nephrotic syndromes, depending on the degree of nephrosis, can have hypercoagulable state, and you'll see that in real life. All right, so this is our problem. The problem, like I said, is nephrotic syndrome is a problem with the podocyte. and the podocytes wrap around the glomeruli. And if you get a diagram, this cartoon, which I also borrowed online, reporting myself, you find that the podocytes are all wrap around the glomeruli, and this is the GBM here. So the podocytes sit on top of it. They secrete things that supply to the GBM, so they help make the glomerular basement membrane. As on the endothelial side, you have the fenestration. Oh, I'm so sorry. On the endothelial side, you have the fenestration in between there, and whatever filtration is happening is going through this fenestration through the GBM, and then there's this slit. Filtration slit process is in between the podocytes, where the filtration eventually goes out, and beyond the podocyte, sorry, this is not, where is my mouse? Okay, beyond the podocyte, anything going out beyond there is going to the Bowman space. You know what that space is? It's urinary space. So things are filtering into there. And so the problem with podocyte, or whatever is causing nephrotic syndrome, has to affect this podocyte structure, such that you begin to hear the word podocyte effacement. If you've ever done nephrology, then you hear that word effacement. Now, effacement means that the structure or the cytoskeleton of the podocytes, because it takes something to keep those podocytes in shape. They have fenestrations that have support in them, and I'll show you a slide to show you that. And whenever something affects the cytostructure of the podocyte, I'm so sorry, this is not showing well. Okay, it flattens out. So you begin to have podocytes flatten out, and eventually, because they don't have the kind of skeletal support in them, depending on whatever damage is caused to them, they can actually pull off. So you have podocyte food process effacement, flattening out, and detachment of podocytes. That's part of the problem with nephrotic syndromes and things that result in nephrotic syndrome. Okay, so look at this picture, and I don't know if you understand some of things that this is a cartoon schematic of the things that make up a podocyte. And I must tell you that every day we're finding out new things that can go wrong to make a podocyte go bad. So from the cytostructure, you begin to see things that make up the podocyte, from all this actinin 4 to this notch to the... All these little names you see here, which mean something to somebody, have all been linked in some way or the other with abnormalities that can result in the breakdown of integrity of the podocyte. And if that result, they can result in some type of nephrotic syndrome. So you're finding every day some genetic familial link to some disease that will cause nephrotic syndrome. It's all because of some of these things we are getting to know more and more. And in between the podocytes, you have things that hold your slit, that slit lamp or slit filtration space in between the podocytes. You have things that bridge and form the slit diaphragm, the nephrin, the neph1. The names that I don't have to bore you with, but nephrology fellows will need to know some of this. But they're things that keep the integrity of the podocyte. So it's so important to know that so many things can go wrong. It's amazing why we don't have everybody having nephrotic syndrome. With all these kind of things happening in your kidney, you're still moving around somehow. But for one to go bad, problems. All right? All right, it's another slide I borrowed to tell you all the things that can cause food process effacement. So impaired formation of the slit diaphragm, which we saw, the joint in the slit, if the nephrin or the neph1, those things get damaged, yeah, there's going to be a breakdown. You can have abnormality of adhesive interaction between podocytes and GBM. So those podocytes have to hold on to the GBM. If anything breaks in, trouble. And the list goes on alteration of transcription. If you don't transcribe well, if the cytostructures, the actinins, and the things that make up the skeleton of podocyte is damaged, they can all result in problems. Mechanical stress, ischemic injury, toxins, you name them. There's so many things that if they get round to damaging these podocytes will ultimately result in nephrotic syndrome, where you leak proteins that should not come out. Okay? All right, I'm boring you all already. But in this conversation, I'm not going to go too technical, but we're going to talk about this particular common causes that you are expected to know in medicine of nephrotic syndrome. Minimal change, your FSGS, focal segmental glomerulosclerosis, your membranous nephropathy, and then what I call the secondary nephrotic syndromes, which you deal with every day in your clinic, diabetes. Diabetes is a form of nephrotic syndrome. I hope you know that. It's just that the way it happens is what you all have to manage in primary care. Amyloidosis, which you don't see a lot, but it's there. And some of these fibrillary, immunotactoid, HIV, you see those, but these are the ones you deal with in medicine. And they sometimes like to bring out in your boards and ask you questions, okay? All right, let's talk about minimal change disease. All right, so as the name implies, there is minimal change. Simple, no change. So it has to be present. Now, I put some pictures there. I don't know if they come out well for you guys to see. But if you look at those pictures there, the structure of if you look at the slide, the presence of nephrotic syndrome with a normal histopathology appearing renal tissue on biopsy. There is no cellular proliferation. There is no immune deposits there. There is no tubulointerstitial changes or fibrosis or changes to worry about. There is no alteration in the glomerular basement membrane. Everything on microscopy looks okay. But clearly, something's wrong. Because the structure or the function of the glomeruli clearly showing that something's wrong. Now, the only abnormality is diffuse effacement and fusion of the podocytes, which tells you that there's a structural problem somewhere along the line. Something's affecting the integrity of the podocyte because it's now flattening out. It's no longer standing upright as it should. It's flattening out, meaning something happened to that podocyte. Now, why or what led to what? It's still a big mystery because there's so many things that they're finding now, but you can't say one size fits all. And sometimes it's futile to even try to find what led to what. But you kind of see the clinical presentation. So in clinical manifestation of this problem, it accounts for 90% of idiopathic nephrotic syndrome in children. So it's almost a non-given. If kids, some of you are pediatricians, yeah. If children come to you less than 10 and they're coming and swelling, their face is puffing up, everywhere is puffing up, and you know that they're spilling nephrotic range proteinuria, many people don't even biopsy them these days. Pediatric nephrologists just assume the first go around, it's got to be minimal change disease. And then you start the common treatment for which is steroids. But so 20 to 40% in adults. So we still see it in adults. It's nephrotic syndrome usually with massive proteinuria. What do we call massive proteinuria? Sorry? Greater than 3.5 grams. Say smart guess. But that's protein. I'm sorry? Yes, we can. So massive proteinuria, I'm talking about people who are spilling 10 grams and higher. And you'll be surprised. People spill up to 20 grams, even higher than that, of protein in their urine daily. It's amazing how much protein you can spill. But these people, minimal change disease does not spill tiny, minuscule protein at all. No. It's the grandfather of I am spilling like crazy. It's spilling 15, 20 higher. But above 10 grams, I would say, is massive proteinuria. They're spilling there. Now, occasionally, because you think there's no abnormality structure, they can have some hematuria. It's allowed. And many of them don't have hypertension, but it's in about 20% you could get hypertension. And usually above 40 years in 15 to 30% of adults. And they can have acute renal failure. The problem with spilling a lot of protein is that it is a setup for trouble. When you spill too much protein massively, the reason why they get acute renal failure, because typically you think there's no structural, or rather no histologic abnormality clear. Why should they have acute renal failure? Well, when you spill that amount of protein through your tubules, it's bound to do some damage. First of all, you're losing so much that you can't even keep your vascular space intact because your proteinuria is so much. Most of them have serum albumin that's about 1 point something. And that can keep your vascular integrity well. So you're spilling and leaking all this stuff, your intravascular volume depletes. So there's a lot of reasons for acute renal failure in some of these people, including the proteinuria they spill. The immunoglobulins that you check, C3, C4, all normal. And some of them can lose so much immunoglobulin, sorry. I meant complements that you check. You check complements, C3, C4, they're normal. But they can lose so much of the protein as immunoglobulins that they actually can be hypoglobulinic and prone to infection, which is a very common thing with minimal change disease. Spontaneous remission occurs in high as 40%, and good long-term prognosis with less than 5% going to ESRD. Typically, the rule is with children, they recover. Many of them will. If it occurs in adults, you have to hold your breath and see how they respond. Some of them, most adults, typically the people that fail therapy, usually adults. Okay? All right, so the pathogenesis is easy. Nobody knows. But, people link minimal change to permeability factors that, that they think T cells are involved. And some research into this, that there's some permeability thing that is affecting the podocyte. And I tell you, everybody's looking for this permeability thing that they can blame for, to give a one-size-fits-all. But seeing the structure of the podocytes and all the things that can go wrong, it will be so hard to ever find one thing that will explain why everybody has minimal change disease or some type of nephrotic syndrome, okay? The causes are, well, idiopathic. Nobody knows. It's just there. It happens. And that's a big chunk of people that get it. Now, other things they're doing, drugs. You have to know this because drugs are very common in NSAID. A lot of people take NSAID, and you'll be amazed how many people just chew it like candy. And they come to see you every day in your office, but you probably don't know unless you see them down and quantify how much they take. So NSAIDs, if you see somebody having proteinuria, massive proteinuria, inquire about NSAID because that's one common thing that's causing a lot of problems in our society. And you can fix this problem even without the biopsy. Or you tell them stop the NSAID. And you'll be surprised how people get better when you stop those medicines. So lithium, interferon, allergy, bee sting. We've known bee sting for a long time. Neoplasms. Neoplasms can do minimal change. Typically, it's the hematopoietic type of malignancy. So you see things that have to do with some blood type cell. Hodgkin's lymphoma, okay, lymphocyte kind of thing. Chronic lymphocytic leukemia, thymomas, and then you might have some like pancreatic cancer involved. But if you get a board question and they tell you all these guys feeling massive proteinuria and they give you, by the way, a story that rhymes and looks like it has malignancy that might sound like, oh, it's a lymphoma or something, don't even think twice sweating about this minimal change. That's what they have. That's what they're trying to get to you in that board question. So minimal change is more related with those type of hematopoietic blood type cancers, whereas membranous, which you will see later, has to do with solid organ tumors. More solid in lung cancer, colon cancer, those solid organ tumors with membranous, which those are just pearls for your boards because you can get some questions right with that. All right, management of the minimal changes, steroids. That's all we have really that work in children. More than 95% will respond. And you have like 10% that become steroid dependent. And some people that don't respond, maybe 5% that don't respond, you have to use all the things we've tried. We've tried calcineurin inhibitors, the cyclophosphamide, the mycophenolate. They've tried all kinds of those regimens with some success, some case reports, and people improve. But steroids is still the grandfather of minimal change. That's the first line medicines you try, okay? I put this here because there's, if you type on your internet and type for the KDIGO guidelines or GN, there's a big PDF that's free online. You just look through. It gives you medicines and doses of how to treat some of these things and things to pay attention to. So I just put it there in case somebody is so interested and wanted to know what other things and the doses they use. It's there. You can find it online. But steroids, prednisone is still the standard glucocorticoids for minimal change. Then the other supportive things you have to do, because low salt diet, yes, makes sense because there's swelling. You have to reduce the absorbing all the salt. So cut back. Diuretics you need to use. This is where you come in. This is what you do. You're going to monitor as a peer, a medicine doctor seeing the patient. The diuretics, the low salt diet. And then you think of immunizations for people that are pouring out all this amount of protein. Always think that they are high risk for infection. You can get from edema, SBP, all kind of stuff can happen. Pneumococcal vaccine, you have to prophylax and take care of some of that when you have patients, in case you're seeing a patient like that. Now, FSGS. FSGS is also on the spectrum of podocytopathy, as they're called. And some people almost say that, sometimes it's hard to say, is this a spectrum of disease? Minimal change and FSGS. Because just like minimal change, the difference in FSGS is that they have some area of segmental sclerosis that you see on their histopathology when you do their kidney biopsy. It will look almost all normal in some cases, Yet there will be if you just see one segment of segmental sclerosis in somebody that's spilling protein, and you think there's problem, and by the way, you check their electron microscopy and they have this global effacement of their podocyte, that's FSGS. As opposed to minimal change, where you don't see the sclerosis, but they have almost similar features, but just missing is that sclerosis that you see on the slide. So if you look at this picture I put on that side, you will see that this part of this kidney, this area, looks a little bit scarred down. You can't see holes like you will see in the other part, meaning that there's some sclerosis there. Even though everything looks okay, there's sclerosis there. All right, so it's more common in African Americans, like you know, and it's probably, and there's segmental sclerosis, like I said in here. Some of those technical things, trapping, like I mentioned, you won't see immune complexes for sure. They're not normally there. But if you see some, it might just be trapping because of the degree of proteinuria. And FSGS is interesting because it can give you a wide spectrum of protein range. You can have, depending on the class of FSGS, you can have degrees, and I'll show you that when we get to the slide. But the pathogenesis of FSGS is another big topic. Like I said, those podocytes have so many things that can affect their structure, and every day they're linking something to some type of FSGS. I can't keep up with the list. It's coming out some genetic marker and something that's called. But for the most part, we've always thought nobody really knows for sure. And the links we're making now is because of better improved technology we have, but no one size fits all. Okay? Recently, there's this super, as it's called. Some of you might have read about it, but there's a soluble urokinase plasminogen activator receptor. And a recent publication, 2011, linked it in idiopathic FSGS. That some people have this super that tends to come in, and if you follow this cartoon diagram I have here, you see the super is made by all these monocytes and neutrophils. And it goes through the kidney and gets down and affects the binding of the podocyte to the glomerular basement membrane. It affects different areas, affects those structures there, and eventually begins to flatten out the podocyte. In other words, some of the damage has been linked to this super. Is one of the most recent literatures out there on things. But there are other things that have been linked to FSGS. The bottom line is that the list of damage or where the damage occurs is in the podocytes. That's all you need to know. There's some podocyte injury, okay? And it's a list of so this top part of this list talks about the classes of FSGS. I don't know if you see that very well, but there are about 5 different pathologic report classes of FSGS. They will talk about the classic FSGS, and they talk about the perihilar, and they talk about collapsing. And why I'm saying this is because some of your questions in your board will pin you down on some of these classes, especially with which one is more steroid responsive. I don't know if you all see some of those questions, but it might come at your board. So there's a T lesion, there's a cellular lesion, and I'm going to show you pictures of this. But secondary causes, drugs. So you see the list, interferons, even your bisphosphonate, palmidronate is among the list of drugs that can do FSGS. Infections, you need to know about HIV. And HIV is, what type of FSGS does HIV cause? See if you're still awake. I'm sorry? Yeah, you're correct. It's a collapse. We talk about collapsing variant. You need to know that when it comes on your board. Neoplasms with FSGS, so some lymphomas and leukemias have been linked to it. And then you have other things. You talk about oligonephronia, where you have diseases that reduce the nephron size, sickle cell disease, reflux, all kind of things that damage the amount of nephron size. The list is long. As you can see, the topic is big, so the list has a lot of things that will do it. Post-infection scarring, where you've caused some damage and you've reduced the size of nephron mass. The truth about FSGS is that it can exist as a common final pathway of any glomerular disease. So if a glomerular disease is affecting the kidney and is damaging it, finally, at the time of the end of damage, by the time you biopsy that kidney and it's scarred up segments of the kidney, it's going to look like focal segmental scar. They'll call it scarring. And it's pretty much everything gets down to FSGS type of damage in the end. Okay? But, you know, there's idiopathic forms. All right. So, like I said, FSGS is a more indolent form. If you check the different degrees of proteinuria you can find, it can range from just 3.5 or even less than that to massive proteinuria. And which one will give you massive? Who knows? Okay. Collapsing FSGS. That's why you have your HIV patients. If they really have HIV-Associated Nephropathy, which is typically a collapsing variant of FSGS, they spill protein like crazy. So you get an HIV patient that comes in with 12, 20 grams of protein. It's that common. And we'll talk about it. The complements are usually normal. Your serologic markers are usually normal in FSGS. Hypertension occurs in about 30 to 50%. And you can have blood in the urine, hematuria in 25 to 75%. You can see that. And the EGFR, can drop in 20 to 30% at the time they present. Now, the problem with FSGS is, unlike minimal change, it's not as responsive to steroids. We'll talk about that. So I put this here because you need to know some of this. The TIP variant of FSGS, and the TIP just means that the pattern of sclerosis is close. It's just where the sclerosis is abound. That's pretty much how they get their name. Okay? So TIP variant, if you need to memorize it, you will see it because they tell you this patient had a TIP variant of FSGS. It only tells you that they can respond better to steroid. So if you see a TIP variant, it have better prognosis with steroid. That will be your first line action. Just treat them with prednisone. Chance of response is better. And you will have questions on this. I'm sorry. The collapsing variant. Okay. The collapsing variant is with HIV. You can also have it with some interferon alpha and palmidronate. And if they ask you about the virus that can do it besides HIV, your parvovirus, some of you know that already. Your parvovirus B19 has also been linked to FSGS with collapsing variant. But HIV is the grandfather of them all. Okay? Cellular variant is just that they have a little cellularity to the scarring that they have. It's just a name. That doesn't link to any prognosis or anything. And then there's FSGS not specified, where the sclerosis doesn't fall into any of these specified groups. Pathologists have all these funny descriptive terms they use, Doesn't tell you much about prognosis except for TIPS. The TIPS variant will respond to steroid. All right, so this is a cartoon of almost all this. And like I said, I got this online. Pictures that will tell you where the lesions are. The collapsing variant means that the structure of the glomeruli crashes down. So the cytostructure of the glomeruli, if you see it in the light microscope, it collapses on itself, and that's podocyte and everything is all off place, and they're just peeling protein like crazy. That's why they have massive proteinuria. All right, let's move quickly on this. All right, so therapy is, you try steroids, but the response rate to steroid with FSGS is not so exciting. Most of this FSGS that we see, they tend to, it's just people grumble on eventually to, most of them will eventually grumble on to renal failure in the end. But 5 to 10% can have spontaneous remission. You need to know that. 50 to 60 respond to corticosteroids with partial or complete remission. And that's like half flip of a coin. Who's going to respond? You never know. But you try it anyway because that's the first line steroids. And but most people, those that don't respond, cyclosporin and cyclophosphamide have been tried with some degree of success. So you notice most of our medicines are the same, kind of. You hear with nephrology, immunosuppressive meds, they kind of have a rhyme. We just keep trying the same medicine, hoping for some result, And sometimes we're lucky, sometimes we're not. But it makes it easier when you have the same medicine. You kind of know what they can do and what they can't do. Okay. End-stage renal failure in 5 to 7 years. Many people will grumble onto that eventually. Keep spilling protein until they get there. And you need to know that after a kidney transplant, some degree of FSGS, not all of it, but about 30 to 40% can reoccur after kidney transplant. And most of those ones have familial FSGS pattern. And so if they ask you about diseases that can reoccur after transplant, FSGS is one of them. Okay? And I think I just put that for those who are interested in knowing doses of medicines and how we do them. It's there. But steroids, pretty much the first line, and then immunosuppressive agents after that. Now we'll come to membranous. You're going to get a lot of questions about membranous nephropathy in your board. If there's any question, they find ways to craft this thing back and forth, but it's going to come out. So you need to know about membranous. It's about 15 to 33% of adults with nephrotic syndrome. It's almost a toss-up. People are getting to a point where they say FSGS, membranous, which one is occurring more? Because as you see, there's so many reasons why people can have membranous nephropathy. But FSGS still has the edge, but membranous is, if anything, next second or very close. It's a very common in adults. I'm talking about nephrotic syndrome in adults. Membranous is a very common disease. It's idiopathic in 70 to 80%, meaning that the secondary causes of it just cause things that make secondary causes about 20 to 30% of membranous. And also, most people have it idiopathic. It's idiopathic membranous. Male more than female, and usually in the age of 30 to 50. So the rule is, if you have a middle age 30 to 50 plus, it's more common with Caucasians, I would say, than African American. If you have 30 to 50 African American with proteinuria, what will be your first thought process? What would you think they have? Nephrotic lung protein. I'm sorry? FSGS. If you have it with the Caucasian, what will be your first thought process? Membranous. It's very common more with them. And it doesn't show up well here, but if you had the staining, you will notice what we call spikes. I put it up there just in case somebody wants to be a nephrologist and needs to see those. Sorry, this is not showing. But you have what we call spikes that you see on the stain. They kind of shoot out like spikes on the, this is a Jones stain of the kidney. And that's kind of diagnostic once you see that, because those are your immune complexes staining interspaced in the glomerular basement membrane. That's what you call spikes. And the pattern on immunofluorescent staining is a granular pattern. Sorry, that's not supposed to happen. What did I do wrong? Okay, this should go back. Uh-oh. All right, what did I do? I have to close it, correct?
Yeah, I mean, you could just go to PowerPoint.
Let's see if I close this. Will they close? Okay, good. All right. All right, and then on the electron microscopy, you can see on the glomerular basement membrane, you will see the dark patches in between there. Those are your immune complexes that typically would occur in membranous nephropathy. All right, so this is a cartoon. Okay, and I borrowed it online. Okay, and this tells you what's really happening. So antigens deposit just under the podocytes in the glomerular basement membrane. So you see the triangular things there, the antigens that are depositing there. They are right there under the podocytes and the GBM. And then you have antibodies that kind of seem to float around and come around and to your fenestration, bind with these antigens, and they form a complex. And once they form this complex, they tend to trigger off a disruption of the podocyte structure, architecture, and the function of the podocyte. And clearly, that's your recipe for I'm going to leak protein, period. And that's your nephrotic syndrome. You start leaking protein. All right, so the protein leak with membranous. Membranous is interesting. Membranous is a disease that you can see variation in the range of proteinuria. So the patient might come to you, first you check their protein concentration is like 3.5, 4. If you don't do anything, by the next time they come is like 5 or 6, and next 7 or 8, and they're climbing. They kind of can do that. I'm climbing up, and they can climb to very massive levels of proteinuria. It's another disease that can give you massive proteinuria. Might not start there right away, but it can climb up to there. Okay, and that's typical of membranous when you see somebody who's changing their grade of proteinuria slowly like that with a disease that looks like it's idiopathic. That could be that membranous will do that. And the renal functions most of the time is preserved. So they come with mostly normal renal function. Complements can be normal. Now notice the next line. Renal vein thrombosis is found in 10 to 30%. And at some time during the course of disease, they tend to form. If there's any nephrotic syndrome that will form clots, this is the guy. So if you have a question where they tell you all the stories and say, oh, okay, by the way, we did an ultrasound somewhere and they found renal vein thrombosis, just go to the bottom of the page and find the answer and check membranous. Forget everything. Don't read any long story anymore. Okay, that's the one that will do it. It's notorious for forming clot. So a lot of causes for it. Like I said, it's idiopathic in 70 to almost 70 to 80%. But the secondary causes autoimmune, because lupus is one of the things that can do it. Rheumatoid arthritis, the list goes on. Infectious cause, Hep B, Hep C, drugs, gold, penicillin, NSAIDs. Look at NSAIDs again. NSAIDs so notorious. In fact, I just finished with a young 20-something-year-old who was chewing this ibuprofen like candy. And was pregnant along, and she was pregnant, noticed proteinuria, and eventually she had a baby and came. And with biopsy, that was membranous, and nobody knew the story about the candy chewing habit with ibuprofen. So we just started saying, hey, do you chew ibuprofen? He said, oh, yeah, it tastes sweet, so sweet, I like it. Eventually, we stopped the ibuprofen, and 6 months after, her proteinuria that was almost 6 grams, I checked her, I saw it just last week, is 300 milligrams. She's back to normal, everything's fine. And that's the treatment. So you do see those things. Membranous is, okay, time. Yeah, I'm going to finish this one quickly. Membranous is a disease of 1/3. It's a big topic, people. I don't know why I jump into it all the time, but I jump into it. It's a big. But the remission in 1/3, spontaneous, can happen. 1/3 proteinuria can just keep limping around and dancing around, different degree of proteinuria, and they stay well. Those ones don't even go to end-stage renal disease. They cannot keep a degree of proteinuria up and down. And then the last 1/3 will progress to end-stage no matter what you do. And treatment is a big graph, but we use immunosuppressive medicines depending on the grade of proteinuria. And we try to use, if you're maintaining proteinuria over 4 grams, so actually over 6 grams typically, if you're staying 6 grams and higher, more than 6 months, that's a recipe for treatment. You have to treat. And we use immunosuppressive medicines. I can't go into details of that. But I'm going to rush it because you need to know about diabetes as a secondary cause of nephrotic syndrome. Very common. You all see that. Now, how long? I put it there for you. How long does it take? You know, people get all these patients that come in and you're wondering, oh, is this diabetes? Is this not diabetes? Why do they have protein? Diabetes does not do protein in 1 year. So if you diagnose somebody in 1 year, it doesn't give you proteinuria in 1 year. So if somebody is diagnosed newly with diabetes, assuming it's truly newly, and they come in and they have, how many seconds do I have? 5 minutes. Do I have up to 5? 2 minutes. Oh, man, it's cutting my time. Assuming they're coming in for less than a year with diabetes, you guys see this. If you're seeing proteinuria that is nephrotic range and they're new, you should be thinking something. Don't just assume it's diabetic nephropathy, you know. But it takes good time. In type 1, 10, 20 years, mainly because they're younger people and they have to have time to damage the nephrons enough to start getting trouble. And then type 2 is shorter because they are older people who have burnt off some nephrons from age, and when diabetes hits the leftover ones, they're in trouble already before you know it. So older people, quicker time, younger people, longer time, depending on how bad their sugar is, you know. But, you know, race and African American, everything bad, African American will kill you. It's just pick African American, that's number 1. And then if you have to pick a next rate, pick Hispanic, number 2. And you have to pick anything, pick, you know, white. But hypertension, cigarette smoking, all that goes. I'm sorry, my niche. I'm just a stickler for wasting time. But the pathogenesis you have to know, it has to do with your glucose. You think your glucose is acetylating things. There's some glycolytic products that are damaging in the mesangium. That's usually where this happens. And that will eventually alter the integrity of the glomerular basement membrane, as well as the podocytes, and damage, of course. It's a long story here, but that's pretty much what's these nodular things you see there are your chemister Wilson nodules. I'm sure some of you know it. If you remember Miss Amanda Wilson, you always have to remember chemister Wilson, because they tend to throw it out there in the board and show you some nodular things. It's your chemister Wilson. Diabetes is not the only thing that will do it. Some other things can do it, but diabetes is one of the most common reasons why. This is a slide I wanted you all to see, how the stages of progression with diabetes, you know, 0 to 3 to 5 years, okay? So they're doing what? Renal hypertrophy. You always have to remember there's hyperfiltration in the first few years of diabetes. So they're hyperfiltrating in 3 to 5 years, and the eGFR is higher, increase, 150. They're running that high. 3 to 5 years, then you start seeing, if you cut their slides, some thickening of GBM, and also some mesangial expansion. Microalbuminuria, believe it or not, 7 to 15 years. That's when you start seeing them start spilling little protein. By the time they're going to 15, 20 years, their proteinuria is entrenched. Because that 7 to 15 years, blood pressure starts becoming a problem. They start having high blood pressure. So just know, once you start seeing in your diabetic patient who's had diabetes for a while, and they begin to now have high blood pressure, you begin to see what's happening. There's some evolution in the kidney, blood pressure now becoming secondary to what's damaging there. And by the time they're all diabetic patients on dialysis, all of them have high blood pressure and kidney failure because they've evolved into that. All right. Management, glycemic control. I'm just going to skip on that. All right. I was going to talk about amyloidosis, but you probably have to read about it. It's a nice pictures I found online that you can see. But
can you continue that in your next lecture?
Okay, next lecture is actually short. Okay, why don't we pause that? Let me continue my next lecture because that was a shorter lecture, I think.
Okay.
And then I can finish it. So let's stop here, take a break.
All right.
And
So guys, stay there for a couple of minutes. Dr. Desai wants to make an announcement.
oh, okay, this it's my pal.
What's up, Reggie? How are you?
I'm fine. Let's go.
Kate, what did you teach him? GN? Oh, yeah, how do you stop it?
Can I stop?
Okay,
I can keep
we can
up.
cut it.
I'll keep it.
Don't worry.
Just put a thing on it. Put your hand on it.
I'll
I don't
stop
want
it
you
here.
to know we're recording what I'm about to say.
so sorry.
That's okay.
Don't worry.
Okay, I'll be quick. I know you guys got to go to the bathroom and take a break. And
No, so it's painful. What do I do? So, how do okay, yeah, just
Start chilling then.
all right. Sorry about that, but I guess we're back. Back with amyloidosis. I put amyloidosis, actually, let me go back one slide, and I'll tell you about monoclonal light chain related renal disease, because if there's any cause of nephrotic syndrome that we tend to see among the elderly, amyloidosis and what the light chains do to the kidney is another big thing, because start seeing people, interestingly though, I'm beginning to see people, all my amyloid patients that I've had biopsied were less than 40. Now, you'll be surprised, and it's surprising to me. I'm still trying to figure out why in this area, maybe it's the soda or the drink or something, I don't know, but why we're seeing people less than 40 here. I've had 3 of those now, they're all less than 40. But it's actually a common problem with nephrotic presentation. So monoclonal light chains can affect the kidney in so many ways. It can affect the glomeruli, and you can have light chain and heavy chain deposition diseases in the glomerulus. Of course, AL amyloid is also something that affects the glomeruli and deposit in the glomeruli. Cryoglobulins also immunoglobulins, so they play a role in this picture too. So they can affect the glomeruli. And then they can affect the tubulointerstitial compartment. And if you think of the kidney and compartmentalize it, this glomeruli is one part of it. I call it the filter. It's like you have the filter. You have to have a filter. And then you have your pipes. Your pipes are your tubes. And I tell my patient, your filter is not working or your pipes are not working. And then you also have the tubulointerstitial compartment, which supports or the coating for the pipes, and they support the pipes, they keep the pipes in place, which among that coating in tubulointerstitial is add the vasculature or the vascular supply. So you can also have vascular things that all those different compartments, the vascular, the tubulointerstitial, the tubules itself, which is included in tubulointerstitial, and the filters, your glomeruli, can all have different diseases that select those areas to attack. So your tubulointerstitial compartment can have the cast nephropathy, which you see in your myeloma kidney, which is a very common question they'll throw out to you, myeloma kidney with casts in the kidney. They can also deposit along the tubules and give a Fanconi type syndrome. And Fanconi is simply just that the kidney has tubular damage and it's leaking out things it should not. So in a Fanconi patient, you might find what? You might find glucosuria when they don't have diabetes. They might have low phosphorus. It's very common. Those are the 2 big things: phosphorus, glucosuria, and even proteinuria. Proteinuria we just take for granted, but those are things that if you see in urine, in somebody is just leaking them and they don't have any other reason to be leaking that problem, you think Fanconi type damage injury. And immunoglobulins can do that. And tubulointerstitial nephritis itself, where they damage that compartment by just inflammation, can happen. Of course, there are vascular lesions from injury to the vascular supply. And all this hyperviscosity is also something you see with monoclonal injury. And you guys that don't see much of it, except your hemonc. Here, all this will come with their big Waldenstrom or whatever they have, and they have the viscosity so high that is affecting their kidney function. neoplastic cell infiltration, and all that. But so the diseases and injuries that you get with immunoglobulin is so varied when it comes to the kidney that sometimes the kidney biopsy will be what it takes to separate out what exactly the component of involvement. But when we talk in terms of nephrotic presentation, classically, the one that presents nephrotic is this guy, Mr. Amyloid. Amyloid will come, and you have to think about it to diagnose it. If you don't think about it, sometimes we don't even think about it, and the patient is coming for something else, GI bleed or something, and they do a GI biopsy and take pictures. Oh, there's amyloid in the tissue. And some pathologists, they don't really go staining with Congo red unless they're actually thinking about it, or somebody stimulating and saying, well, think amyloid here. So it's caused by the deposition of abnormal fibrillary structures composed of precursor proteins, and then 25% will present with nephrotic syndrome. So if you have a nephrotic syndrome in people that you just don't know what's happening, always think amyloid. It could be one of the reasons. So fat biopsy is 7 to 80% sensitive for diagnosis, and then the gold standard is your Congo red stain is positive. Amyloid is Congo positive, and when you do the polarized light, you get this green, apple green birefringent picture with polarized light, but the stain is actually it stains orange with Congo red. So you stain it and then you do this apple green with polarized light. Okay, and that's only amyloid. Only amyloid will do this. All the other deposition diseases, they don't. First of all, they don't stain with Congo red, and they will not polarize on polarization. And you'll see some of them. But amyloid classic is the diagnosis. Now, of course, you know there are other causes for amyloid. There are the classic AL amyloid is the one we're talking about, which is idiopathic, and of course the ones we see your hemo patients have is AL amyloid. Amyloid light chain, that's what AL stands for. Then there's the big group, AA amyloid, which you see with which people? Who has AA? You'll tell me, you're reading the books now. AA, wait a minute. So AL amyloid is the amyloid light chain that you see classically with hemo patients, and it's bone marrow. AA amyloid, AA. You all know what AA is, correct? Okay, you don't know amyloid. I'm sorry? All right, so you should know that there are different types of the proteins that make up the amyloid fibrils can be distinguished into what composes them, you know? So the amyloid light chain that you see with AL amyloid is a classic one. And I took out the slide. I had all the list. I thought I didn't need to bug you all with that. But the AA amyloid is the one you see with chronic inflammatory disease or infectious disease. So somebody that has chronic osteomyelitis, or I have Crohn's disease, or rheumatoid arthritis, something that is chronically stimulating inflammation, they can form amyloid. In that picture, the amyloid fibrils is made of AA amyloid, not AL amyloid. In other words, the light chain is not the component forming the cytostructure of the fibril. It's actually the precursor proteins that you put out with inflammation. All of the amyloid, why they stain and Congo red, is because they have this thing called substance P in them, that's in the composition, that keeps it stable in the composition of that fibril. There's a particular architecture that will have to exist for you to stain as amyloid. And so the AA will have that structure intact, but it's not made up of light chains. That's why the amyloid light chain is the one we talk about with kidney disease. But AA amyloid can also give you nephrosis in some people. Some of them, I wish I had the table, some things affect some organs more than other organs. AL, which we deal with, is notorious kidney. It can affect the heart and the kidney. Those two organs are pretty more selection of where it can affect. But AA amyloid is chronic inflammatory state. You should know this because they ask you a question with somebody with osteomyelitis, chronic osteo, or Crohn's disease, or rheumatoid arthritis that's been dealing with inflammation for a long time, or by the way has proteinuria, and they expect you to know that this is likely because of AA type amyloid, not the AL amyloid. I'll let you read that by yourself, but if you have any questions, you can meet me and we'll talk about it. Now, immunotactoid and fibrillary GN are also deposition diseases that involve proteins. However, they are bottom prints, but things that can come out because somebody feels like, oh, yeah, somebody should hear about this disease because they're there in the books. Immunotactoid, the distinction, these diseases are rare, very rare. Of the group together, fibrillary GN will make, I've seen only one case of fibrillary GN, who's my patient. And they make up, fibrillary is more common than immunotactoid. And it all has to do with where the deposits occur. They are larger fibrils. The size of the fibrils is bigger than what you see in amyloid. Amyloid has small fibrils, or have the smallest of the fibrillary deposition disease is amyloid. But the larger fibrils are immunotactoid and fibrillary disease. And it's usually idiopathic, but it can be secondary in some leukemic patients. Some leukemias can result with fibrillary tongue tie, and immunotactoid. Now the picture I'll show you is just where the depositions occur. In fibrillary GN, you have depositions within the basement membrane cells. So what you see here is this is fenestration from the endothelial cells. All the way to here is the GBM. So it's thick, full of deposits. That's because of these big, randomly arranged fibers. If you look, this is not showing so well. Sure. Where is this? Oh. Okay, there it is. These are all fibers that are depositing all inside this huge GBM. Now that's in fibrillary GN. In immunotactoid, it's actually subendothelial. So this is your GBM from here to here. It's normal size. However, there's this huge deposit that is under the GBM and pushing up the endothelium up here, the endothelial part of the cells all there. So this is a huge deposit, and it's fibrillary, and with EM you can see it, and that's immunotactoid. They're rare, but I just felt you needed to know it. It's common in the elderly population or mid-age to elderly, and it will do nephrotic syndrome of varying degrees, and hypertension, microscopic hematuria can exist, and they can progress to ESRD. In fact, the rule is, there's really no defined treatment for it. People use immunosuppression. The one we had, which I think was a case we're trying to put up, but we did use Cytoxan, but in a different regimen, and they responded, luckily for them. But most people, I'll say the bulk don't respond as you expect, and they all limp through and progress to end-stage renal disease within 10 years. Some people have tried all kinds of things. NSAIDs have tried, colchicine, plasmapheresis, all kinds of things tried, but no established guideline for treatment. All right, HIV. HIV is the one you all see, and you have to know about HIV, not an association with kidney disease, HIV-Associated Nephropathy, HIV. So it affects more, again, black people, African American. Anything you have to guess African American. It's bad for kidney. Okay. Proteinuria is rapid, and renal deterioration is very rapid. And you will see why the deterioration is rapid, because this is collapsing FSGS. And the collapse is that, I don't know if you see it very well here, but if you look at the structure of this, okay, look at here. This glomeruli is actually, this has all collapsed down here. What you see here is just the epithelial cells of podocytes. This is not a crescent. This is a pseudocrescent, which is just podocytes that are hypertrophied to fill up the space of the collapsed glomerular tuft. That tuft, you can't even see any capillary loop open. It just, like a bomb, just collapsed on itself. And that's what HIV folks tend to have. It's not the only disease HIV can have or can cause for the kidney, but if they have HIV-Associated nephropathy, it's usually collapsing FSGS. Now, the people that tend to get it, so most of those people will have their CD4 count is usually less than 200, and they have very high viral load. So you think it's normally people that are the worst of the worst HIV, not necessarily so, but they tend to have detectable virus, which is on a high level. The CD4 counts are low, and the kidneys can be echogenic. Now, this is normally a point where I ask people, what is the size of the kidney with HIV? Small, big, very big? No change.
Very big.
So she says very big. Who supports? Oh, I have a supporter. So yes, the kidneys with HIV are usually big. They're big, and I throw it out there. There are 4 main diseases you have to know that cause chronic failure of the kidney, and yet the kidney looks large. All right? One is HIV. Number 2 is what? I'm sorry? Polycystic kidney. That's not okay. Which one? Amyloid. So deposition disease, number 3. What's number 4? Number 4 is your bread and butter. You see it all the time. I'm sorry? Say it loud. Diabetes. Say it confident. So diabetes, number 4. So those are the 4 big diseases that you have to deal with and see that have large size kidneys, but yet those kidneys are failing and are dying. Those are the 4 diseases. So with HIV, I showed pictures, collapsed FSGS. Sometimes they have cysts in the tubules that you can see. I didn't put that picture here. They can also have interstitial inflammation because of the disease itself, and sometimes because of the therapy of the disease and things that damage the kidney. But eventually, the thing with these people is that they spill so much protein. If you see a true hive, most of them don't have high blood pressure. And you can understand why. Because when you spill a lot of protein, well, guess what? Your intravascular compartment is depleted already. So when you start seeing some people with very high blood pressure, and you wonder, do they have hive? And I most can exclude. It's not 100%, but when somebody calls and says HIV and they're proteinuria, and I'm first of all I quantify how much protein. Say, oh, you have hive, and I say maybe not. What's his blood pressure? Say, oh, it's sky high. I say, well, maybe not. This is the kind of guy I might want to biopsy to know if there's something else with HIV or without HIV going on that kidney. But most of the HIV proteinuria is massive, and they typically don't have high blood pressure. But that's kind of where it can exclude. The treatment is your heart therapy. So used to be that when HIV came out newly, people just didn't have heart therapy and we didn't know. So we tried what we knew best. We tried steroids. And interestingly enough, steroids did work for some select folks of HIV. So some people still think of corticosteroids in selected cases. They tried them. It worked. But now the standard of treatment is your heart therapy. So if it comes on your board, put them on heart therapy. And you never know who improve. Usually, kidney disease and HIV go hand in hand a lot. Sometimes it's the therapy of the HIV. Some of the medicines they use can damage the kidney. But HIV-Associated Nephropathy is also real and affects, like I listed, some other diseases things that can happen to the kidney with HIV. It's MPGN. MPGN is not a disease. It's a manifestation of several diseases in the kidney. So when you use the word MPGN, it's not like it's one disease only. It's just a pattern of injury you see with the kidney that a lot of diseases can do. Okay, IgA nephropathy can coexist with HIV. Lupus-like syndromes can. HUS, TTP can. You know that, correct? So when you get all your TTP patients come and we say, did you check an HIV? You have to check it amongst the labs you do because HIV can in itself induce HUS, TTP pattern of injury to the kidney. And then there's some immune complex kidney diseases that HIV can do. All right. This is the first half of the question. I just picked some of the diseases that I thought would be relevant for you all to know some things about. Question? Yes?
Since there are patients that have nephrotic syndrome are prone to thromboembolic events, is there a role for prophylactic anticoagulation?
Oh, you just asked the $1 million question. And that question has been the rage. Sorry. How do I put? Where did he go? Okay, there it is. I'm sorry. I'll answer your question. I was trying to see if I can pull up the nephritic part of the question. Let's answer your question first. So, you all got a question. People with nephrotic syndrome, why don't we just prophylactically anticoagulate them? And I'll tell you the answer. So the answer lies on, people who have looked at this, there's a camp that says don't anticoagulate or give any anticoagulation unless there's been an event in terms of you've had some clot happen event and you found some clot. So you start anticoagulating. The truth of the matter is that there are several people with significant nephrosis that already have clots that you don't know they have clots. Because you never checked for it. And you've not had the reason to check for it. But they're walking around with clots. It's until the PE comes, oh, by the way, they have all this. But they're walking around with clots. So some people say that's kind of not the right way to go. And some people say, give everybody with nephrotic syndrome anticoagulation. Just put them on something, bam, just go. And that too is not the right way because there are some people who are giving, God forbid, all the bad complications of anticoagulation. They bleed to them when they didn't even have a clot. It bleeds in the brain, bleeds somewhere, dies from GI bleed because you put him on stuff that. So we're trying to find, so what's the best way to know who to anticoagulate or not? Well, the studies that have been done have shown that the smartest way to go about it is to look at the serum albumin. And people go with that. So if your serum albumin is less than 2, and people have done the study, less than 2 is kind of the cutoff people use. If it's less than 2, just go ahead and put them on, because that's severe nephrosis. Because you're losing a lot of protein and keeping your serum albumin less than 2. Some people are losing 4 or 5 grams of protein, but you check your serum albumin, they're still maintaining 3 point something. They're not normal, but they are above 3, you know. And so if it's less than 2, go ahead, put them on anticoagulation. And there are spectrums. People have said if it's clearly less than 2, Coumadin. Now, some people say between 2 and 2.5 or thereabout. If they're above 2, but not up to 3, but between 2 and 3, you can still give them, put them on aspirin. Put them on aspirin. Clearly, anybody above 3 does not need anticoagulation. And you can watch them. So that's the way I go about it. So if your serum albumin is above 3, I won't anticoagulate you. But if you're less than 2, like you see some of these severely nephrotic people, 1.7, 1.8, that is a recipe for disaster if they're walking around and they can really clot. Those ones, definitely, I would say, go ahead and anticoagulate them. And now, things change. If you treat them and they're improving and their protein comes up where they're not in a good range, you can stop the Coumadin. You can then move to aspirin if they're between 2 and 3, or 2.5 to 3. And then when they get above 3, just stop. Make sense? All right. Any other questions? Okay. Manish, where is he hiding? It's not hiding. Okay. Let's see if I can find this, my computer. I'm trying to find, okay, there it is. All right. I hope you don't mind if I just go on and do the nephritic thing and get it out of the way so you guys can go home. Oh, sorry, you're not going home. Just stay here. I will go home. All right, where did I put it? Oh, sorry. Okay, the Nephrotic Syndrome, sorry. All right. What do I do? Okay, good. All right, let's go ahead and do Nephrotic Syndromes. Oh, sorry. Now, like I said, again, I show you this slide. Disclaimer. Diseases can exist in both forms. So don't just say, oh, it's clear-cut. There's really not many diseases that are clear-cut. The ultimate diagnosis is made by doing what? You got to stick a needle. And when you have to remember that, because you can guess and guesstimate, but if you don't have a needle biopsy, you could miss a lot of disease that just present in a different form and you're treating something wrong. All right, so nephritic syndromes normally due to immune complexes. And they will tend to be immune complexes deposition in glomerular capillary wall. And the bullets, hematuria, they typically have hematuria. Be it gross hematuria or microscopic hematuria, they seek some blood somewhere. They're leaking blood. Oliguria and hypertension, azotemia, and they usually have active sediment. I guess people that thought about nephrosis and nephritic, kind of in their mind are saying, oh, nephrosis is gentle and mild, and nephritic is bad because there's blood in your urine. It's different. And truly, that could be the way to look at it. Nephritic disease is probably more aggressive, but to say that there's one that will not, they can all do damage, which is end-stage renal disease. But nephritic suggests I am the bad guy in the room and I'm about to do business with you right now. So nephritic syndromes are usually more aggressive. All right, IgA nephropathy. That's the one all of you are going to get questions on. Because why? It's the most common GN in the world. And if anybody's going to ask you anything about GN, it better ask you about IgA, some question about IgA. So you need to know about IgA. It's common GN worldwide. It's rare in blacks. It's funny. All my IgA patients that I've seen about 4 now here. Not so common here. Well, let's say, that's the 3 I remember. 2 are black. It's crazy. Say what? But because, well, our population here has more black people in Eastern Carolina here than you think in normal places or other parts of the world. But it's rare in blacks. And of the black ones I've seen, they were really bad. They were the ones progressed to end stage. None of my black IgA had quiet disease. It was, I'm bad, and they progressed. It's sporadic. Sometimes some genetic predisposition. Most times, it just happens. But some people have it genetic. So how does it happen? Well, so it has to do with defective mucosal immunity. And so the IgA molecules react to yet unidentified antigens that you get exposed to. And if you know from your anatomy and immunology where you've done, IgA is secretory type of immunoglobulin. It's usually found in those surfaces that are exposed readily to what? To antigens from the exterior surface. So the mucosal linings of your nose, your GI tract, it hides there. And places that get in contact with things coming from exterior, the IgA is secretory, so it lines those areas easily. All right, so there is a problem with abnormal glycosylation. So typically there are two types of forms of IgA. There is the A1 variant and the A2. The problem is with the A1 type of immunoglobulin A, and there's a glycosylation of the hinge. So IgA is a big immunoglobulin. Some of you know better than I do. There's a hinge part between where you have your variable and your light and your constant region. So the hinge area, there's glycosylation that occurs there that makes that IgA molecule, not readily absorbed or destroyed by your reticular endothelial system. It can't clear it easily. And so what happens? It starts piling on. Now that it's piling on does not mean it's just sitting there, innocent bystander. No. It goes in there and then calls its friends, Mr. Complement and all the other friends that it can attract to come and do damage to the structure. So it's not sitting there piling on doing nothing. It's doing something. Okay? So it then triggers an inflammatory response, and eventually there's damage and scarring, and kidney disease fails. And guess what? You start seeing me as a dialysis patient, which is not a good thing. There are other things. So it could be idiopathic. Most times we don't know why it's primary. But there's several things secondarily that can associate with IgA, and diseases of organs like the liver. So think of it. So you're going to be all those organs that have to deal with things that are coming from the exterior get-go. Disease of liver, of the intestine, of the skin, of the bronchus, areas where you're exposed to things. And then some neoplasms that are associated with it. It's listed there. So the list is long, and they're adding more each time. So you can't keep up. There's a lot of secondary associations. But if you ever have to think of secondary, think of those exposure areas where you can get irritations and antigens that get into your body that can stimulate IgA. And that's where you get all that from. All right, so presentation. Mostly with hematuria, gross or microscopic. And the commonest thing you find is a young kid, 12, 13, gets a strep or supposed infection in his throat, pharyngitis. You see it all the time. Your board question is always there. Pharyngitis, sore throat, and few days after or GI infection. Few days after is peeing blood. You're going to get a lot of questions about this. Kid has sore throat or GI infection, pees blood. It's connection. You think of some certain disease. What diseases would you think of in that picture? I got a sore throat, and few days after, I'm getting to pee blood. IgA is one. Which other one? Okay, so she's saying in post-epidural, it's going to be, the time lag will be there, because it's going to be constitute immunity and eventually happen. But IgA is happening. They get infections, they're peeing blood almost right away, because IgA is waiting to do some damage. So 40% can present asymptomatic microscopic hematuria. That's kind of what you see. A kid goes to a pediatrician, and the pediatrician dips his urine, and by the way, there's blood. We check the blood, and eventually send to nephrology. Now, in parts of the world, like in Asia, Japan, where they report most of the IgAs, it's because their tradition there is any blood we see in anybody, we're sticking in it, we're biopsying. In America, it's not that. American kids get a lot of people have blood walking around, but nobody's sticking them. We just watch other risk factors that we think might portend to worsening, or the person is going to be a high risk for problem. So you kind of select out who you biopsy. So for that reason, we probably don't see as much of the IgA as we should here. But parts of the world where they stick everybody, they see a lot of that. Okay. So the treatment, I just put this here for people who are interested, but the bottom line is what you look at there. There's people that have risk factors that put them at a high risk to progress. IgA is such a tricky disease because even till now, everybody's scratching their head trying to see what is really the risk factor that I need to worry about. And honest to goodness, we don't really have a good consensus as nephrologists, or even pathologists, of what exactly we need to be paying attention to. There's some things we know. From the biopsy, so the mild one on the mild folks here, if you look at the result of the histology, mild histology, no risk factors. Well, okay, what risk factor? Of course, African Americans always a bad risk factor. I'll tell you that one. But if the biopsy looks mild, no significant fibrosis on their kidney or tubulointerstitial scarring, you kind of know that this person, if they don't have high blood pressure and their level of proteinuria is very little, then you can kind of watch them. Monitor the patient, you monitor closely. Monitor blood pressure. If there's no hypertension, things you worry about. Hypertension, proteinuria, if it's not too much, if they're not African American, and your kidney histology doesn't look so bad. You monitor them, watch them closely, kind of pay attention to your kidney. If anything spooks you anywhere, then you kind of move to the next thing and start some form of treatment. For those who have evidence that they have more proteinuria, or I'm little bad, I'm not the low risk guy, I'm not the very high risk guy, but I'm kind of showing you that I could be somewhere. It's clearly because they have more proteinuria, and maybe they're African American, or maybe they have a little finding of a little more scarring that you see. Clearly, you start those people with ACE ARBs. We really don't have good effective treatment for this disease. It's just that we try what we have. And some of them you cannot consider prednisone if you think this guy is looking like, it could go south. Let's just start prednisone and see if we can keep him in check. So some people start steroids at that, but like I said, steroids is just you're throwing it in. You don't know how they respond. But majorly our medicines we have are the ACE and the ARBs that we can use to reduce proteinuria, control their blood pressure very well, and kind of watch other things, reduce protein in their diet, things we know we can do to minimize progression. And then it goes on from there. By the time you get to a higher level of degree, now we're not getting to the hocus pocus and heebie-jeebie point where you're trying anything to help, Of course, you put your ACE and ARB, omega-3 fatty acid, where use them or not to use them. We agree to use them because, we can't do any more harm. Just throw it in there, And we put it there and we kind of go from there. Bottom line is that if IgA is progressive, you can throw the kitchen sink on top of it. It will keep progressing until eventually it scares you to end up on dialysis. I saw a 23-year-old, last clinic on Wednesday. Lost to follow-up, 2004 diagnosed with IgA, 2014, 10 years on the trot. She is CK84 now, and she's there. I've told her the sad news that I might be seeing her on the other side with dialysis very soon. Membranous proliferative GN, MPGN, like I said, MPGN is nephritic most times, but it's not a disease. It's a pattern of injury. And the reason it's because of chronic damage and repair. Damage and repair, that's what you see. And what the body is trying to do is to try to repair what the chronic injury is doing, and then it begins to layer on things that you now see on slides and pathology that make up the constellation you find with MPGN. Now, if you look at the cartoon things I put out there, I hope I can see my head there. Now, in the old classification, some of you still have, I don't know if it will change with your boards, but the textbooks will still have type 1, type 2, type 3 MPGN. Has anybody read that before? I forget I'm not talking to kidney people. But old classification was type 1, type 2, type 3. Type 3, for all intent, is like type 1, so people don't even talk too much about type 3. But type 1 and type 2 was the type of classification that you had. The disease mostly, immune complex, but it's not just limited to immune complex. Like I said, it's chronic, anything that's chronically insulting the kidney. So if you think of it, whatever is in MPGN must be there for a period of time. Think of chronic infections. And things that have chronic infections, your Hep C, Hep B, typical Hep C. So the first old days, when they had MPGN 1 and 2, MPGN 1 was linked to Hep C because they found out by the time we could not detect Hep C, most people that had the so-called MPGN 1 had Hep C. So the conclusion was that, it's Hep C doing it. And they were right in a sense because most of those people had chronic insults from Hep C, and so they linked that to MPGN type 1. But clearly we know better, and we now know that it's a lot of chronic diseases that can hang around, can do this injury. So more recently, the classifications of MPGN, and if you check in your more recent textbooks, it's changing to reflect the nomenclature that many more diseases can do this besides, MPGN type 1, Hep C. That was the only thing I had. Then MPGN type 2, which you guys might hear, if you heard of dense deposit disease. Has anybody heard of dense deposit disease? Okay. So dense deposit disease, let me move on. But dense deposit disease, it's a problem with the alternate pathway of complement. So you have the classic pathway, you have the alternate pathway. The MPGNs that you see typically will affect the alternate pathway, and that's why it's a disease when you check the complexes, C3, C4. Most of the time, C3 is normally low. You can have both low, but C3 is a guilty player with MPGN disease per se, but I won't bug you all with that. It's kind of technical. It's hard to draw the line where you need to know what you're doing, but I'll tell you everything. All right, so this disease is just a bad disease. Like I wrote down there, typically grumbles on to end-stage renal disease. We really don't have a good treatment for MPGN, except you know the cause, except you know the disease entity that is responsible for it. So some people have idiopathic MPGN. You never know what caused it. But if you find a disease entity that you think was responsible player, you can treat that disease and hope that you get the response that will make the kidney do better. But for the most people that have it, it just grumbles on to end-stage renal disease. So, like I said, the classification is changed. Oh, I should have taken this out. Sorry, this is the same repeat of my slide. This is the newer classification that they're trying to throw out now for MPGN. And it's simple for any renal person involved. It's a simple, straightforward. It's 3 main pathology classifications, or laboratory things that you find with pathology going with it. It has to do with C3. Like I said, it's an alternate pathway disease. C3 is key player. So you have the class where you say if you get the biopsy and you stain for C3 in the biopsy, if you have C3 and an immunoglobulin staining also, so you have an IgG or IgA or some kind of immunoglobulin staining together with this C3 in your kidney immunofluorescence, then that has to be an infectious line or some type of monoclonal gammopathy or monoclonal involvement damaging the kidney. Like I said, the key here is that this is a chronic insult, something that is doing some damage chronically. So people have monoclonal damage to the kidney. A lot of infections you see there, strep, all this stuff here, infections that you might not necessarily associate with in the developed world because you have antibiotics that can take care of some of this stuff. In some parts of the world where people don't see antibiotics like you see here over the street, some of these diseases don't just come and stay, they stay onwards. So some post-infectious things that linger on. And linger on, eventually by the time you see them, they're having kidney damage on top of the fact that they have a chronic infection on top. Those are the things that will do C3 with an immune complex when you do their biopsy. Then there's the C3 ones that stain only C3. You just do their kidney biopsy, there's damage, and you stain it, it's only depositing C3 on it. There is your big player, dense deposit disease. Dense deposit disease is just that there's C3 deposit all around the GBM. There's no space anywhere, just deposit with C3. You guys don't need to know that. But then there's also C3-associated nephropathy, where it's not dense deposit, but it's just a C3, a pattern of injury that's affecting your alternate pathway and causing C3 to deposit in the kidney, not like dense disease, but it is what you find in pathology. That also exists. And the last classification is people you get their kidney biopsy and there's no staining, no C3, nothing. Yet they have a pathology find that looks like MPGN. And if I go back one slide, the key hallmark of MPGN is this thing I put arrows on there called double contouring. It's the glomerular basement membrane splitting in two. Why? Because you've chronically damaged it and then a new membrane is trying to form on top of an old damaged membrane. So when you stain it, you see double staining of 2 layers of glomeruli. And you can see that clearly. You see this one stain here and another stain here. It's a double stain. It's a double contour, and it's classic for MPGN. And that's a hallmark of I have been beaten down. This kidney is suffering a lot of beat down. Sorry, I better move fast to get away from you guys. So that's the new classifications, but you guys will hear more about it as you hang out with nephrology more. Presentation is varying. Hematuria, proteinuria, EGFR declines. The complements are usually C3, C4 tends to be low. I put out this disease with viral hepatitis because they asked a lot of questions about Hep C and Hep B. Hep C has C3 and C4 that can be low when you check if there's a disease with Hep C. Usually it's cryoglobulinic disease with Hep C. But the hallmark with Hep C is that in some patients, you will find that their C4 levels are markedly more depressed compared to C3. In other words, they're both low, but C3 might be, say the normal C3 is 100 and you get 85 to 90. C4 normal might be 25 or something, and you're getting 7, 6. It is much more depressed than C3 would be. Okay? Sorry, I move on. Hep B typically is not MPGN. Hep B usually you associate with membranous, but you can have MPGN also with Hep B. But if you had a viral disease that you have to associate with membranous, Hep B typically. Management of MPGN, nobody knows. Doesn't just treat the disease that you can identify that is causing it. Otherwise, most of people just progress to end stage. Post-strep is something else that you know, like you mentioned. 2 to 3 weeks after a strep infection, that's what you say. You need time for the antibodies to develop and attack the kidney. And after that, then you see the protein. You see them having hematuria. Your titers of your ASO, 70% positive, and your anti-DNase, this is not DNA antibody, this is DNase B, so you know different, is 90% more positive. So you check for both when you suspect strep infection. It might help you. And it has to do with, I can't tell you more about this, but nephrology fellows, we need to know. The hallmark of diagnosis is in the biopsy. You get to see these large, humpy immune complexes that you see. It's characteristic. Once you see it, it's a post-infectious or post-strep type of pattern. It's humps. We call them bodacious humps. Immune complex bodacious. Sounds dangerous. All right. Oh, time. Yeah, no. Lupus is a big one. I can't tell you everything about lupus, but I'll tell you that lupus. I'm sorry?
Do you want to do a separate lecture for lupus?
Okay. You like to work me hard, don't you? Well, I think lupus is I think that's reasonable. Okay, let's keep lupus here, and then let me just jump lupus to, well, anti-GBM and all. I might just have to come back. I think you guys, but we have the anchor diseases that we've not talked about. We have it's a bunch of, do you mind if we just take 1 or 2 questions for people here who just want to know questions? Or do I let this nice man come and do his thing? He doesn't mind. He'll learn something. All right, I'll let somebody read this one question. We'll do 1 or 2 questions and I'll be done. Okay? So who wants to read fast and answer this question? You all know this one. Nobody? Okay.
25.
Okay. Manish, go ahead.
25-year-old with type 1 diabetes for 10 years, presents with progressive bilateral edema 4 months ago. A spot protein creatinine ratio was 0.1, which is an adaptive incident, and aspirin. Blood pressure is 160/90. Cardiopulmonary fundoscopic exam normal. A1C 7.1, albumin 3, creatinine 1.1. Urine protein creatinine ratio 5.2 grams. Urinalysis shows 3 plus protein, 2 plus blood, 8 to 10 dysmorphic RBCs, 8 to 10 dysmorphic RBCs. Few RBC costs. What is the appropriate next step? Cystoscopy, kidney biopsy, spiral CT of abdomen, pelvis, or observation?
Okay, you said what? Biopsy. Okay. Now, these are mix-up questions. I went to a mix-up and picked them, and I wanted just to know what the kind of things that you got to do a kidney biopsy. This one is placed. I mean, this patient, you don't know what's going on. The only way to know is to do a kidney biopsy. Okay, the answer is B, the kidney biopsy. Last one, and I'm gone.
19-year-old female with 3 months of periorbital and ankle edema with foamy urine. Medical history unremarkable, no medications. Pressure is normal, BMI normal, respiratory normal. Exam normal except 2 plus leg edema, creatinine 0.8, urinalysis 4 plus protein, no blood. Ratio is 10 gram. Kidney biopsy performed and shows diffuse food process assessment, and light microscopy is normal. No immune complex deposits for immunofluorescence, no immune complex deposits, which is appropriate treatment for the patient. Cyclophosphamide, cyclosporine.
Okay, so what did you say they have? Minimal change. All right. So once you see 10 gram proteinuria, only few things get to 10 gram. It's minimal change, collapse in FSGS, and membranous. If the story fits like minimal, this sounds like minimal, it's minimal change. All right, I'm going to stop here. Oh,
Would you
sorry.
biopsy that patient?
Okay, so this is a 19-year-old. Well, so like I said, most pediatric population is almost pediatric. They won't biopsy. They'll try prednisone first and see how they respond. Then if they fail prednisone or they don't respond as they expect, or they're steroid dependent, in other words, you have to keep them. If you try to taper out prednisone, they start spilling protein again. Then you might have to biopsy. Because the spectrum of minimal change and FSGS is so close that they could actually be FSGS hiding there. And you want to know. But if you treat them and they respond, you know it's minimal change. This is. Thank you very much. Any question? Last question? Thank you so much, people. Yeah, maybe we'll do lupus next time.
We're going to take a quick 2-minute break. It's been a long day. Thank you for cooperating. We've got to learn about my chart. It's going to be an important feature in your inpatient as an outpatient setting. So let's take a quick break and we'll get started with my chart training. case we can get started early so you guys can get out early.
Sorry,
All right, that's fine.
I need to. Sorry, man. I'm trying to
you're
get
good.
this out. I want to
I'll-
eject it out from the,
Sure.
the stuff. Yeah, that's the. Thanks, man. So
Thank
maybe
you.
if we need to do lupus, maybe next time we'll do lupus. But if you have a time, just let me know.
Right.
All right.
There you go.
Thank you.
Thank you.